A very good morning, afternoon, and evening, everyone. My name is Triagebot. I'm a senior public health scientist with the Public Health Foundation of India, and I co-direct the Center for Sustainable Health Innovation here in Singapore. Welcome to this day's session on AI applications for health systems planning and delivery. We have an exciting lineup of speakers ahead. And before I go ahead and introduce them to you, just offering a little bit of context. So AI offers a number of advantages, as you know, and as COVID has revealed over traditional analysis and clinical decision-making in health systems today. And learning algorithms can be incredibly persuasive and precise as they interact with training as well as data, allowing an unprecedented insights into diagnostic care, precision treatment, validity, patient outcome, as well as prevention. And today's session is really going to be exploring some of these. So I'm delighted to introduce our first speaker for today's session. Our first speaker is Mr. Jay Patel. He is the Technology and Analytics Manager of Jacaranda Health from Kenya. And in his presentation, the title of his presentation is Using AI to Help Mothers in Kenya Get the Care That They Need Faster. So over to you, Jay. I think we're just waiting on to load the presentation.
Hi, my name is Jay Patel, and I'm the Technology and Analytics Manager at Jacaranda Health. And I'm going to talk to you a little bit today about how we use AI to get mothers the care they need faster in Kenya. So the challenge that we're facing in Kenya is that a full 1/3 of maternal deaths happen because of delays in seeking care. On one side of the equation, mothers sometimes don't realize when they're in a situation where they need to get care urgently. And on the other side, government hospitals are dealing with a huge volume of clients and can't often offer the highly personalized care that moms sometimes need. And certainly it's hard to do that affordably also and at scale. So in partnership with the county governments, we're working to deliver a package of low-cost and scalable interventions so that we can help ensure that all mothers experience childbirth safely and with respect, and all newborns get a safe start in life. And so there are 4 pillars to our solution. We start on the left-hand side. When a mother visits one of our partner health facilities, she can sign up for our free SMS-based service, whereby we send her maternal and newborn-related health information. Moms are then free to ask us any questions about their health or the health of their baby. And we have an AI augmented help desk, which answers the questions that we get from our clients. And by the way, we get questions in English, Swahili, and a mixture of both. So we just crossed 200,000 moms enrolled in our service. We have around 96,000 monthly active users across almost 300 health facilities at the moment. By the end of next year, we expect to be reaching about 40% of the births across the country, with the eventual goal of reaching every pregnant woman nationally. So about half of our users ask us at least one question, with a handful asking us more than 25 questions. We're currently getting about between 8 and 1,200 questions a day. And so the first challenge we face as we deal with the increasing message volumes from our rapidly expanding user base is how do we answer these questions without compromising quality, without also exponentially increasing the size of our help desk staff, and then lastly, without letting the response times to these questions get out of control. There is an additional challenge here, and that is that while most of the questions we get are benign, so questions like, is it okay to eat avocados or eggs or drink soda during pregnancy, about 1/3 of the questions we're getting that are potentially medically serious. And these are questions relating to danger signs like headaches, bleeding, or swelling. And so how do we answer the urgent questions first, right? So how do we find, identify, and answer the danger sign questions before, for example, before we get to the nutrition questions? And that's where the AI comes in. We've implemented natural language processing tools to help us deal with these challenges. And how we started is by taking the thousands of questions that moms had asked us and assigning labels to each of these questions. So the avocado questions, for example, were categorized as nutrition, while the headache or bleeding or discharge related questions were also labeled accordingly to the question's intent. We started out with about 40 intent categories, but have since refined our list and continue to refine the list to improve the accuracy and usefulness of the NLP model. But the initial data set that we trained, we fed that into multiple different machine learning models to see which one performed best for our purposes. And then after some further experimentation, refinement, and retraining, we arrived at a final NLP model, which we called Triagebot, and then we deployed that into our help desk's workflow. So this is a screenshot from our help desk platform. And how Triagebot works is that it reads every single incoming question first. And then it does two things. It assigns the intent or category to each question along with a corresponding priority level, and then attaches a predefined suggested response to the question. Now, based on the intent categories and priority levels, our help desk team can then filter for urgent and high priority questions in a way they weren't able to do prior to the deployment of the bot. And then they can answer these urgent and high priority questions before moving on to the medium and low priority questions. The suggested response in the example you see on the page allows our team to copy and paste the response into the answer and then edit that response to suit the mom's particular situation before sending the response out to her. And with some further iteration and retraining, we've gotten the detection accuracy on urgent questions up to about 95%. And we're constantly working on improving the accuracy even further. And so what kind of effect has this had on the help desk? As you can see here, the response times went down significantly in the months immediately following the deployment of the AI. And more importantly, urgent and high priority questions are answered in about half the time that it takes to answer less urgent questions. Now, one important thing to note is that we're always keeping the human in the loop. Because of the volumes of questions that we get, just the sheer amount of questions, along with the subject matter and the kinds of questions that we're dealing with, even an accuracy of 99% isn't really good enough for us. And because of the consequences or the potential consequences of the machine reading and responding incorrectly, and because the consequences can be quite dire, we don't want to have our bot talking directly to the moms, and we run everything through our help desk agents first. And so the automation and the AI that I've discussed that we've put in place is not to replace the human in this workflow, but to augment our help desk team in order to make sure that they can help empower moms with the information they need to get the care, that the moms can actually get the care faster and in a way that is both affordable and scalable. And most importantly of all, actually leads to better health outcomes for pregnant women and new mothers in Kenya in a measurable way. Thank you.
Thank you, Jay. Our next presenter is Dr. Lillian Utiso, and her presentation is on what can social media tell us about programming for adolescents and young people, data from a Kenyan digital platform. Dr. Linian is a medical doctor with an MBA in healthcare management and has over 10 years of clinical research and programming experience. As we wait for Lillian's presentation to load, a quick note to all those who have tuned in. Please use the Q&A facility on the HSR platform to enter questions that you may have for any of the speakers in the course of their presentation, and I will flag them to ask towards the end of the session. We also have a discussion board at the same platform that you can use as a chat forum, maybe share your perspectives or even exchange information with our presenters and yourselves during the course of the session. So while we are waiting for Lillian's presentation, please do, we'd like to encourage you to ask a couple of questions on Jay's presentation, which we will definitely flag with the end of the session.
And good morning, everyone. Good afternoon and good evening, wherever you may be. My name is Dr. Lilian Otiso. I'm the Executive Director at LVCT Health, a Kenyan NGO that is involved in delivery of HIV services targeting and sexual reproductive health and gender-based violence services targeting vulnerable and marginalized populations, including adolescents and young people in Kenya. So today my presentation is about social media and what the data from social media can tell us about programming for young people. And that's really based on work that we have done as an organization since 2011. So from the introduction, in Kenya, we know, and actually across the world, that adolescents and young people are the most affected by HIV and sexual reproductive health needs. And AIDS continues to be the leading cause of death among them. So digital technology has really come up as something that can be used to address these gaps in access and utilization of services. And mobile phone penetration has increased significantly. For example, in Kenya, the number of active mobile phone subscriptions is more than 100% of the population at 55 million people. And most of these phones, people do have access to smartphones, so they're also able to access digital technology. And LVCT Health has been using an integrated digital platform to reach adolescents and young people with HIV and reproductive health services since 2011. The platform itself, we call it the one-to-one integrated digital platform. The flagship is the hotline. It's a toll-free hotline which anybody can call using the short code 1190. And it's manned by youthful counselors who are able to address the needs that are coming up from the young people or anyone else who's calling the hotline. Then the hotline is supported by other platforms, including a bulk SMS, Facebook, Twitter, Instagram, and others, and even a blog page. So these platforms, as I mentioned, provide this opportunity for young people to interact and engage with counselors. And we've had counselors for a long time who are trained on addressing these issues of adolescents and young people. It addresses issues affecting youth, such as HIV, contraceptives, abortion, gender-based violence, amongst others. And it is complemented by mainstream media, where we do promotions and activations. So we have radio, television adverts, and now social media adverts that really encourage young people to talk and call and get more information. So these are the different campaigns that we've carried out. And my presentation today will be showing how these campaigns have helped to boost people's participation and how it varies depending on the campaign that we had. So the analysis that we have, we did a data analysis for both the hotline data and the social media data. The hotline data looked at demographics, reasons for calling, and the service offered. For example, when someone calls or you're referred for something, and all this is collected from using tools that are on the online platform as the counselors are handling the calls. Then social media is tracked using analytics by third-party agents. So we did an analysis of data that we had in 2015 and in 2019, and that's because we did campaigns at those times. In 2015, we did a campaign on contraceptives, and in 2019, it was one on HIV self-testing. So we assessed the callers who were reached by age, sex, and the reasons for calling in both years. And for the social media, specifically in 2019, which is when we started tracking it, we were able to look at age and gender disaggregation of the callers. So what results did we see? We were able to see, this is just a snapshot of some of the results we identified. that in 2015, we had more female callers than male callers at 62% to 38%. And you can see there the female are in red and the males are in blue. And this was simply because we had a campaign on family planning and contraceptives. Prior to that, and even subsequently after that, the ratio was always the opposite, where we would have more males than females. So on the right, you can see the graph for the HIV self-testing campaign, which was done in partnership with Population Services Kenya, who are offering the HIV self-testing services. And the purpose of the hotline was to offer information about it, where to get it, and how to do the test. So in this one, it reversed to what we were used to, where we have 42% female and 48% male. Overall, for the hotline, we tend to have more of the older, in terms of over 25. No, we get a lot of 20 to 24 and even 15 to 19, but sometimes we have over 25 callers. But we get the younger ones increasing when students are on holidays and such platforms, when they can be able to access the information. So this also shows in terms of access who has the phones and whose phone is being used and their age, even if the information could be reaching the adolescents and younger people. So an analysis of the reasons for calling the hotline, this is a recent analysis from the HIV Self-Testing Campaign, as having started as a call center for HIV services, that remains the main reason for calling us. Then now, because of the campaign, HIV self-testing increased. Then the other reasons are interpersonal relationships, which has remained very common. And these are relationships between boy, girl, or their parents or their friends, and what is affecting them about that, and they require counseling. But we also specifically ask about sexual practice. People do ask about sexual practices. As an organization, we do serve key populations, such as men who have sex with men. So we do get calls from people who are asking about sex and wanting to have sex with someone else, both male or female, same-sex or heterosexual contact. Then pregnancy and birth control, together with contraceptives, has always remained major. And now we have more calls on mental health, including suicide, coming through. And for those, we offer intense counseling and referral services. So on the social media aspect, we did, as I mentioned, the analytics, and we're able to track who is calling, why are they calling, and I mean, who's reaching us by age and gender. And as you can see from all the three different data sets presented, majority of callers were male in all cases, but age varied. So we have Facebook having more men aged between 18 to 24, while Instagram was actually for those 25 to 34. But one challenge we've noted with social media trying to track this data is that the younger adolescents, certain platforms don't allow them to enroll as adolescents. So they need to be able to reach out to use their older relatives or parents' contacts. So that sometimes affects the age. But generally, it reaches more men than females. So in conclusion, adolescents and young people can be reached through the technological platforms, including hotline and SMS. And by making it toll-free, it means that it's easier for people to access. And social media is ideal for increasing the access and communication amongst young people. What varies is the age and sex. And what we've seen is that we reach more males than females through these platforms, unless we have targeted campaigns for the females. So we all need to look into programs to reach more adolescent girls and young women and have very targeted campaigns for them when we want to use the social media or hotline services. So that's it. I'd like to just acknowledge the LVCT staff and our beneficiaries, and also those donors that have worked with us to support this program through different times. And those are our contacts, as well as the social media platforms that you can reach the one-to-one platform. Thank you.
Thank you, Lillian. And we'll move over to our next presentation, which is on using big data to estimate the effect of multimorbidity on health spending among adults in the United States. A presenter for this is Dr. Angela Chang, who's an assistant professor at the Danish Institute for Advanced Studies. As Angela's presentation is being loaded again, I'd like to encourage participants to ask any questions on the Q&A box, as well as post any comments on the discussion section so that we can curate those and get our presenters to engage in a conversation once the presentations are done.
This presentation is on the use of big data to estimate the effect of multimorbidity on health spending among adults in the United States. I am an assistant professor at the Danish Institute for Advanced Studies based in Copenhagen. But this is work I did during my time at IHME with Joe Dielman. This work is currently under review in a journal, but we're happy to share our findings and especially lessons I think could be useful for the health systems research community. Given the time limit, I will focus less on the technical aspects and the methods and more on the findings and how this could be applied to health systems research. This is what I'll be covering in the next 8 minutes. So this paper is trying to address this literature gap between multimorbidity and health spending. So it's clear that multimorbidity, often defined as having 2 or more chronic conditions, is a priority in health policy and health research. It is also clear that research on health spending and health financing are needed to understand how we are spending and financing care and how we are explicitly or implicitly setting priorities. The gap is between how to combine these 2 research topics, multimorbidity and health spending. So existing spending studies focus mostly on single diseases, and those with a multimorbidity focus often have been limited due to lack of good data on the prevalence and spending of multimorbidity, inclusion of only a few diseases due to limitations in computational power. Very few have looked at whether the combination of diseases lead to greater or less spending than just the sum of having diseases separately. And most studies do not adjust spending estimates for single diseases based on multimorbidity. So the objective of this study is to study the relationship between multimorbidity and spending among adults from 2 distinct perspectives. Disease combinations. So instead of merely counting the number of chronic conditions an individual has, we are interested in how different types of multimorbidity combinations lead to different spending outcomes. So for example, having 1 cardiovascular disease and 1 cancer is very different than having cardiovascular disease and a mental disorder, even though these 2 individuals have 2 diseases. And the second perspective we take is the single chronic conditions. And by considering the contribution of multimorbidity, so the additional spending that could be attributed to the presence of other chronic conditions. So here are the methods. We use the Truven Market Scan 2014 dataset in inpatient and outpatient datasets, which covers about 700 million claims among roughly 22 million unique privately insured adults in the United States, ages 18 to 64. And so this includes all the service they received, what diagnosis they received, and how much they've spent. We first identified disease cases based on the global burden of disease algorithms using ICD codes, and we were able to identify 68 chronic conditions. We then estimate the annual spending per enrollee and then run regression models to estimate the relationship between disease conditions, the combinations of diseases, and spending, and controlling for typical demographic covariates. And again, we took 2 perspectives, combinations and single conditions. One thing to note is that with 68 chronic conditions, we have more than 50,000 possible combinations of 2 and 3 diseases. Plus, we have 20 million people in the data set. So we use stochastic gradient descent, which is a machine learning algorithm, to apply penalized regressions to derive the estimates. So these are the findings. Out of the 50,000 possible combinations, 67% were super additive, meaning the estimated spending for the combination is greater than the sum of spending of the individual conditions. 13% had 0 as their coefficient, meaning that the estimated spending of the combination equals the sum of the spending of the individual. And 20% had negative coefficients, meaning that the estimated combination spending is less than the sum of the 2 individual diseases. And 2 things to highlight here are, 1, contrary to the common belief, multimorbidity does not always lead to greater spending than the sum of spending associated with having these conditions separately. In fact, 33% did not have super additive spending. And 2, and this study doesn't allow us to make any conclusions, but others have hypothesized around what super additive or sub-additive means. So super additive spending could mean that patients with these combinations use more healthcare than other people, or there's inefficiency due to lack of coordination. Sub-additive spending, on the other hand, could mean that there's more efficiency between the two diseases, or that some required services are not provided and thus may lead to worse health or spending outcomes. So our study does not allow us to answer which hypothesis is correct, but our study does point to which combinations have super-additive or sub-additive spending and are worth studying more in detail. Now focusing on single diseases and looking at the estimated spending once multi-morbidity adjustment is made, we see that chronic kidney diseases, cirrhosis, upper gastrointestinal cancers had the highest spending per treated case. And if we look at the decomposition of the change in the estimated health spending with and without multi-morbidity adjustment, this is what we find in this graph. So looking at chronic kidney disease, for example, estimated per treated spending, a case treated, is about $5,000. And of this 5,000, about 25%, so the green bar, 25% comes from spending just of chronic kidney disease, and the remaining come from the combinations of kidney diseases with other diseases. The size of the contribution of the dyads and the triads, so combination of 2 and 3 diseases, are a function of the estimated spending associated with these combination, as well as the observed prevalence of the combination among people with conditions. Finally, we decompose spending by multi-morbidity disease categories and provide a visualization of the distribution of conditions with the highest spending per treated case. So these 10 diseases have the highest spending after multi-morbidity adjustment. Spending associated with having only the disease itself accounts for no more than 40% of most of these diseases, and that's the gray area that you see in the graph. For cardiovascular diseases such as ischemic heart disease and rheumatic heart disease, other cardiovascular diseases account for the largest increase after multi-morbidity adjustments, meaning that these diseases often tend to cluster with other cardiovascular diseases, and the spending, a large chunk of the spending come from these comorbidities. And for chronic kidney disease and congenital birth defects, risk factors, mainly hypertension and musculoskeletal disorders, account for the greatest increases respectively. And for the rest, the increases distributed relatively equally across disease categories. And so this is the last slide. So there's a lot more in the paper that we're unable to present in this presentation. So please reach out if you're interested in learning more. Some conclusions include the fact that multi-morbidity adjustment is very important and should be done for any health spending analysis if data is available. Otherwise, we largely overestimate some and underestimate spending for other diseases. We've identified a set of diseases that have both high single disease spending as well as contributing to multi-morbidity spending. But these are US specific and specifically in our data set. And so it could be different in other settings. Lessons for our community include the need to move away from a single disease perspective to multiple disease perspectives in various researches that we do. And we've demonstrated how this result changed with this shift. And using applications of machine learning approaches or using existing administrative data sets could overcome some challenges currently faced in the health systems services research. Again, please reach out if you have any questions or if you want to do similar studies on your own, if you have certain data sets that look similar to what we have. Thank you.
Great, thanks, Angela. And thank you all for keeping those questions coming. We already have some great questions that I would definitely like to flag at the end of the presentations. And so please keep those questions coming. They look really interesting. And I'm sure our presenters would be really happy to get into a good discussion around them. Our next presenter is Amalia Hasnida. She's a researcher at the Erasmus School of Health Policy and Management, Erasmus University, Rotterdam, and her presentation is going to be around identifying market risk-based indicators to flag poor quality medicines. So while Amalia's presentation is being loaded again, please do share those questions, and I am flagging them so that we can get those going towards the end of the presentation and have a really good discussion going.
Good day, everyone. I'm Amalia Hasnida. Now I'll present my ongoing research about identifying market risk-based indicators to flag poor quality medicines. I would like to thank my colleagues at Erasmus University and also the USP Quality Institute for supporting this research. We're doing this research in Indonesia, the world's fourth most populous country, which aims to achieve universal health coverage and where most of the medicines are domestically produced. The structural deficit of national health insurance has led to the imperative of cost containment policies, including downward price pressures on medicines. Meanwhile, public procurement regulations applies price as the main auction criteria. In that case, that could lead us to the first market risk factors of substandard medicines, which is the pressured profit margins resulted from increased costs and decreased revenues from industries such as manufacturers or distributors, which might incentivize industry to perform cost cutting. I should specify here that substandard medicines are medicines produced by legitimate manufacturer, but with lower specifications or standards. Two of other factors in this context are limited technical capacity and also limited oversight. Meanwhile, falsified medicines or medicines produced by illegitimate manufacturer by deliberately copying the sources or packaging or sources or packaging of originators or of original products. These particular poor quality medicines emerge when there's a market opportunity for falsifications, such as shortages, or when the falsifiers could reap the highest profit, where at the same time they have less probability to get caught. In this research, we're trying to use these market risk factors to flag products at the highest risk to become substandard or falsified. On that score, we're trying to support the medicine regulator to protect patients from getting poor quality medicines. To do that, we identified potential objective indicators from routinely collected data, including data from public domain, from public, private, and also NGO sources. As we can see here in this table, some examples, some data with various numbers of observations were obtained from institutions outside healthcare sector, for example, the procurement agency. In addition to this, we also conducted in-depth interviews with 23 key stakeholders to validate and interpret quantitative data when formulating these indicators. Next, we went back to our earlier market risk framework, which we mapped each potential indicators to each risk factor of substandard or falsified medicines. Now I want to stress out or emphasize that here are just some examples of the indicators. And I will tell more in detail about some of them in my next slides. And please keep in mind that these indicators are not absolute measures, meaning that they're just indicating the risk, and eventually they have to be ranked and combined with one another as an algorithm to select or to score the highest potential scores of products to become substandard or falsified. In this graphic, we can see that how product price could be used to assess risk for substandard and falsified medicines. we're using amoxicillin in this analysis, given the high utilization, high volume of utilization, and also potential public health implications from poor quality versions of amoxicillin. And each dot in this graphic represents each amoxicillin 500 milligram products in Indonesian market in 2018. The reference price that we use here is the price of amoxicillin 500 milligram in New Zealand public procurement, which is commonly used as a price, reference price for fair price and quality assured products. So in this graphic, we see two different risk zones. First, on the left side is the substandard risk zones, and we use the examples of product price that is less than 2/3 of this reference price, and we assume that this indicator indicates that there's a pressured profit margins from the side of manufacturers. In this pink zone, all products that fall into this risk zone will then be analyzed with other indicators. For example, here, new manufacturers in the market, assuming there's a risk for lack of competence, and the other is product without a valid marketing authorization during the public procurement contracting years. And this one is outsourced production to other manufacturers, or as we call it, contract manufacture. And the last one in this example is the high participation of manufacturers in public auction. On the other side of this graphic, on the right side, is another risk zone for falsification. And if we see here, we use the examples of product price that is more than twice the market median price, this price. And we use the same approach as earlier zone, that we also use other examples of indicators here, such as no valid market authorization for that product, and also if this product is produced by manufacturers that has globally reputable brand. And here we can see that contract manufacturing is also applied or is also carried out for product with premium prices. So not only for product with low prices in these substandard risk zones. This support the fact that each indicator is not an absolute measure of risk. So we still have to rank these indicators and weight them, and also combine them as algorithm to provide comprehensive information before or prior to flagging the final products. From our research so far, we gathered that challenges in healthcare, such as medicine quality, are not only originated from policies directly related to health system, but also from policies outside the healthcare sector. Then we think that these indicators is highly contextualized in relevant health system, meaning that we think or we believe that these indicators will work in Indonesia and also adaptable in other countries. But these indicators will not work the same way, exactly the same way in every country worldwide. And lastly, we learned that collaboration among stakeholders and also potential users, including on how they share, integrate, and also interpret the data is paramount to make this tool works. This is the end of my presentation. Thank you.
Thank you very much, Amelia. That was a really interesting presentation, and I think brings to light really the implications of how AI can be so broad-based in capturing so many areas of health systems weaknesses, including being able to identify poor quality medicines. We will then move on to the last speaker in our series of presenters for this evening. We have Professor Sailesh Mohan from the Public Health Foundation of India, and he will be presenting on implementing a hypertension and diabetes registry, leveraging innovative mHealth technology to strengthen primary and secondary healthcare systems in India. Dr. Mohan is a professor at PHFI, and he's also the Joint Director of the Center for Chronic Conditions and Injuries, and has been teaching and training, and current work has been focusing on developing, implementing, and evaluating comprehensive community and health systems-based approaches to chronic diseases. So again, as we're waiting for Sailesh's presentation to load, I do encourage folks to put your questions on the Q&A as well as the discussion forum, and I'm really eager to open this out to discussion as quickly as possible.
Hello everyone, it's my proud privilege and honor to present some of the work that we have been doing in India for improving the delivery of healthcare for people with diabetes and hypertension, leveraging task sharing as well as mHealth technology. So this is part of a large community-based project called UDAY, which aims to prevent, detect, and reduce the risk of diabetes and hypertension, as well as improve the treatment and management of individuals with either or both conditions in 2 geographies of India, Haryana in north and Andhra Pradesh in south. Within these 2 states, we selected the cities of Vizag and Sonipat, where we targeted adults aged 30 and above, residing in rural and urban areas, and the total target population was about 400,000. We had several interventions. In this presentation, I'm going to talk about the registry program that we implemented. So the registry is a facility-based registry for improving hypertension and diabetes care. It had 3 components: the registry itself, the decision support system, which is an algorithm developed by experts based on latest management guidelines and the feasibility of implementing it in the healthcare system in India, and an element of lifestyle modification. The decision support system was on a tablet-based platform, and here you can see the non-physician health worker taking down the patient details. It was implemented in the primary healthcare centers, in community healthcare centers, in district hospital, private hospitals, as well as mobile clinics where the health system was inaccessible and healthcare was delivered through mobile clinics. All together across both the sites, we had about 10 facilities. So these are some snapshots of the decision support system, interface, history, and the biochemical parameters. So this is a typical output that is generated based on the input of demographic information, clinical parameters, and medical history. Here, the patient has poor glycemic control, so is recommended an increase in the metformin dosage or an additional class of drug along with lifestyle modification. It also advises a follow-up within the next 90 days. So essentially, it eases the clinic workflow and eases the load on the physician. The physician is at liberty to accept or reject it. So if he or she rejects this plan, we do ask them to document the reason. So study subjects were 30 years and above year olds who were diagnosed with diabetes and hypertension. Trained non-physician healthcare workers used the tablet to gather the demographics, medical history, lifestyle behaviors, blood pressure and blood glucose parameters, and then the DSS generated the treatment plan. Patients were recruited at baseline and were advised to return for follow-up at least once in a 3-month period. We followed them over 3 follow-up periods. Definitions we used were standard definitions for blood pressure control and diabetes, and we looked at the proportion of people who had their blood pressure or blood sugar control from baseline to the different follow-up visits. We enrolled slightly over 16,000 patients during a 3-year period. We had more patients in the southern side, more females, and more people in the rural area enrolled. This higher number of females and rural residents is not surprising because most of the public healthcare system is more well developed in the rural parts of India. When we look at the number of visits made by patients, patients with hypertension made the most number of visits. This is not surprising because the prevalence of hypertension is higher than that of diabetes. When we look at the diagnosis, again, large number of people with hypertension were registered in comparison to diabetes. But notably, many people also had both these conditions. Again, when we look at patients' visits according to diagnosis by different follow-up periods, we found that more hypertensives were there at baseline and more number of them came for regular follow-up across the 3 follow-up periods. This was slightly lesser in case of diabetics and even lesser in case of those with both conditions, underlying the fact that follow-up for people with chronic conditions in the public healthcare system today is quite challenging, and we need to do something about it. This is the most important finding. We found that despite challenges in follow-up, we could improve the blood pressure control among hypertensives, in both sides, in both rural and urban areas, among both men and women. We could also improve blood pressure control in both sides, in both rural and urban, and in both men and women. So to conclude, this technology enabled non-physician driven facility-based disease registry program was feasible to be implemented in very resource-constrained primary and secondary healthcare system in India, and also resulted in considerable improvement in quality of care for people with diabetes and hypertension. We saw significant improvements in both blood pressure and blood sugar levels, which were controlled to the recommended targets. One of the most challenging aspects was the follow-up, which was suboptimal. And therefore, we conclude that we need more innovative approaches, more community-based approaches and patient-centric approaches to improve awareness about the need for getting appropriate treatment, adhering to treatment, and following up regularly at the health system or with the healthcare providers so that health outcomes in people with diabetes and hypertension can be improved, and we can also improve the quality of life and the care delivered through the healthcare system. Thank you very much.
Thank you so much, Sailesh. That was a really interesting presentation. And I think there are a whole bunch of really interesting questions that we have in the course of the presentation. Some of them are more targeted to specific presenters, but some of them can be applied to all of the presenters. So we have, let me start off with the first question from Mona Al-Mudwani, and her question actually kind of is around, I think it's targeted at, I think, Lillian's presentation, and her question is around whether app and hotline presented in Kenya is integrated into the national health systems or do they stay as an initiative within the NGO? And I think this question was at the top of my mind as well, because as we look at AI solutions and digital innovation, as they begin to disrupt both health markets and systems, how embedded or integrated are they with existing country health systems? So what is the role that digital readiness plays in many of the countries that you are presenting from, whether it's India or Indonesia or Kenya? And are some countries more digitally ready in being able to take risks in clinical decision making at a population health level than others? And this is one question perhaps I will put to all the presenters. And we also have a specific question directed at Lillian. And this is from Rosie, and she says, I'm curious to whether it is known why the Hotline reaches more men than women usually. So perhaps Lillian, you can get to begin. You can answer that question first, and then perhaps we could kind of go down the room to really talk about the question of digital readiness and health system embeddedness, and how your individual innovations in AI have been able to interact with health systems, or where do you see them eventually embed? Lillian, why don't we start with you?
Okay, thanks. And those are great questions. Actually, the question about why we tend to get more men than women has been something we've been asking for a long time. And we haven't been able to do a study on that specifically, but just interacting with some of our beneficiaries and also reading through the literature, it's a function of accessibility and availability of devices, of mobile phone devices or airtime or smartphones. So most of the time we find men are more likely to have either smartphones or even just access to a phone compared to women. And the younger they get, the harder it is for the girls to actually access that. And it's even harder for them to use, say, their parents or someone else. And it's also been shown they spend a lot more time on either just hanging out with their friends or doing household chores, as opposed to being on phones or technology. But it's an interesting thing, and will actually be good to explore and get more data on that, specifically for the cohorts we serve. And until you target them, currently we have programs targeting girls, and then we're able to reach girls, but social media has been consistently reaches more males than females. On the other question of integrating with the national system, we work very closely with government, and actually our data has informed the government systems. And even the work we do on Hotline has been used. For example, part of the national system for HIV self-testing, this number 1190 is used as the number that people in the country can call. So it's integrated into the national HIV program as a HIV self-testing platform. Though we've also provided technical support to government in terms of setting up other hotlines for different functions they have, which are housed within the Ministry of Health. But that's how we integrate and ensure that we work very closely within the ministry. Thank you.
Great points, Lillian. So I'd like to continue this discussion to the others as well. So, Amalia, you actually talked about using risk-based indicators for poor quality medicine, and Angela actually talked about the effect of multi-morbidity on health spending. How do you see your work in, using AI embed themselves in health systems? Are the countries that you're really working in, are they digitally prepared kind of take on some of these innovations? What are some of the challenges that you've come across in the work that you do?
Okay, thank you, Priya, for your interesting questions. And I would like to maybe emphasize here that the approach that I've been presenting a while ago, it's still in this development phase. So it's not ready to be made like an app or something, but we're still working to integrate the database from different healthcare sectors. So, and also to touch upon the earlier questions of how integrated the database or the big data in the country that I'm studying in Indonesia. So there has been some initiatives from the authority, from the government, to collect public sector data in a greater health systems. But I think the challenge will be the data is quite fragmented, because healthcare is highly decentralized sector in Indonesia. So each provinces, we have 34 provinces across nationwide. So they have different policies, different investment and infrastructures as well to be involved in such a big data approach. But yeah, there has been some initiatives, and I do think that in the future, it's also important for us to move toward a more integrated big data approach. However, there has to be some willingness or commitment from the public authority to also share, integrate, and interpret the data.
Great, thanks. I'd also like to kind of move this question over to Angela. I know that, you know, your assessment was complex in many cases, and multimorbidity presents a very interesting challenge to health spending in the long term because of the chronic conditions that they represent. How have you been able to apply the work that you're doing to some of the practical challenges in the US, especially with relation to NCDs, and you know, how is this going to translate into, say, at a policy level or an implementation level? Where do you see AI really disrupt the picture?
Thank you for the question. I apologize, my video has stopped working yesterday, so I cannot.
No problem.
But I think I'll first answer the question you mentioned earlier with Amalia also, which is, I thought quite a bit about how this kind of approach, my approach, can be applied to health systems research globally in other places, other contexts. And it's challenging, and the challenges are two. One is, so I use administrative data, that's existing data. It's secondary, so we did not collect primary data. And countries that have this type of administrative data are often rich countries, right? So where I'm right now in Denmark, it's very common to have this kind of data. Even in the US, I was lucky because my institute purchased the data set from a private company. And so it's, even in the US, it's challenging to do this kind of thing. So you need to figure out if the administrative data structure is there or not. And most countries don't have that. The second constraint, and I think the main reason most people don't do this kind of study, is computational power. To do something of this much scale, you need high computational power that most institutions don't have. The skills to do it can be learned. Everyone can learn that. But the hardware that needs to be available, plus the money to purchase these data sets are expensive. So it's a bit tricky to do this. In terms of policy implications, I think in the US, and my guess is in most countries, we still haven't moved from the perspective of single disease to multiple diseases. And so the payments, for example, because I study health spending, payments are still tied to individual diagnoses of diseases. Even though we know that multimorbidity is very widespread, even in younger populations. Earlier, there was a question of whether my study can look at adults over 65, because people assume that's where multimorbidity is most commonly there. But in fact, young populations also have more than one chronic conditions at a time. So I think the policies implications that we have is to move away from single disease perspective. And it's not just for spending, it's for clinical effectiveness and so on. But I'll stop there. Thank you.
Yeah, that's a very interesting perspective. We'll come back to that. So I'm just going to shift this a little bit and look at two countries, Jay from Kenya and Sailesh from India. And really this question is around two things. Digital readiness, because I think Kenya and India have been particularly innovative, where in using AI as well as digital innovation, really unpack some of the solutions down the health system spectrum. But both of you deal with AI in the case of clinical presentation and kind of making life more easier, using algorithms to really sift through a lot of data to kind of create applications that make clinical decision making that much more easier and much more effective. But one of the problems with using artificial intelligence, and as it sifts through reams of data, is something called algorithmic bias. And you see it in race, you see it in gender, you see it in social economic status. So a question to both of you: when you are looking at applying AI to clinical decision making, does your program create red flags that perhaps can be a marker to say something is not quite right in this bias, or that there's an inordinate amount of male patients being selected for a certain condition, or in the case of Ray, a specific question kind of comes out as an outlier. And if so, how do you deal with this this element of bias? How have both your programs, do you see them? I mean, is it part of your challenge? And if you do, how would you deal with it? So Ray, perhaps you could share some of your insights.
Thanks, Priya. That's a great question. In terms of the algorithmic bias, we've trained our AI specifically on the questions that we get from moms, and we're not using off-the-shelf models to like just process the text that we get. So off-the-shelf natural language models, we've trained it specifically on the questions we get to try and make sure that it will pick up the issues as accurately as possible. To your point about there are questions that we get which are very much more common than others. So nutrition questions, for example, are much more common than questions about headaches or rather about bleeding, just because bleeding is not as frequent an occurrence as maybe someone asking about what kind of diet they should have during and after pregnancy. So one way to deal with that is just to reduce, when we do the training, just reduce the number of nutrition questions, reduce the amount of noise that goes into that, to try and push higher the ones that the higher impact issues. And going back to your point about digital readiness, most of the public health facilities here don't have electronic records. We do have dashboards that we want to feed back to the facility so that they can make better decisions on what's happening on the ground, along with the counties. And what we've learned is not to put the dashboard up and ask the facility to visit it. We'll make a copy of it and send it to the in-charge's email. In certain cases, we actually just print out the dashboard and hand it directly to them. And that's, we found the best way to actually get them to note the data and action on it.
Yeah, great point. Sailesh, you've been, the Uday project, interestingly, has such an uptake at rural levels. So how have you, overcome some of these challenges?
Thank you, Priya. Am I audible?
Yes, yes.
Okay, sorry, I have a problem with my laptop camera, so I can't be on the camera. So essentially, I will answer to address 2 points that you raised. One is readiness, and second, what are the challenges we encounter when we bring in electronic or mobile based decision support systems in rural primary care mostly. So first, I think there is a movement now towards digitalization in different spheres of both health and non-health sectors. So in health, some initial efforts towards a national or an electronic health record have started. So we are now working on a project that dovetails or integrates our decision support system with the government's electronic health record. So I think in the coming days, electronic health record and digital methods of keeping records are going to increase within the health system, particularly the public, because in the private there are different kinds of electronic health records and elements of digitalization, but the problem is most of them don't talk to each other. So I think the government also is cognizant of this and is working on common standards so that the systems can talk to each other. With regard to what difficulties we faced, ours is not actually just an electronic system or a decision support system. So it's tied with task sharing or task shifting, that is utilizing non-physician health workers and re-engineering the clinic flow along with the electronic DSS to improve, to first of all reduce the load, alter the flow a little bit so that the patient gets appropriate care and there is efficiency while providing services, and ultimately it can lead to improved outcomes. So we have worked on this in this area for about a decade, and we have demonstrated through various studies. Many colleagues have conducted many studies at different levels of the public healthcare system, and this decision support system has proven to be effective in improving management and improving outcomes. So in this particular case, what we did was we tried to improve the data collection system by placing this non-physician health worker within the clinics so that the data collection is streamlined. In any case, there is an element of data collection, but it was not done very well. So using that information and the parameters that are necessary, bare minimum parameters that are necessary for the decision support system to run and spit out the personalized management plan, we approached the problem in such a perspective. So it works on minimum clinical parameters, minimum personal parameters. For instance, it can run on just a fasting blood glucose reports, or it can also run on a HbA1c report, but it depends, on the availability. So the physician can run it, or the staff can run it based on either. So similarly, for blood pressure, it's pretty straightforward. You just need a blood pressure reading. So essentially, the challenges in terms of technology are not that much, but in terms of getting people to adopt and implement it consistently so that there is fidelity to intervention is pretty challenging, given that they're used to a different system. And this is in a research mode. So if you do it in a real world setting scenario, so I think it will be slightly more challenging, because here there was a staff to do it, but if you don't have a staff, existing staff have to do it, I think there will be some challenges. But again, the question is whether, right now, people where technology is used also do the paperwork. So this will work well when they have to do just this and not do both. So I think those are some perspectives to some of the questions.
Great point, Sailesh. And I think I'm going to use that as a segue. We have, I think, about 5 minutes more. So, I mean, for those of you all who are listening in, please do put in your questions so I can kind of flag them. This question of data is fundamental to the way health systems are reacting today. I think what COVID-19 has taught us in the last 1 year is that never before in the history of the world has so much health data been connected across so many different spheres. And this is going to have huge implications on AI applications in health workforce, in estimating costs, in clinical decision making, in many of the areas, in messaging and prevention, which is really the gamut of today's presentation. In fact, according to industry estimates, the next 10 years, as many as 50 billion medical devices is going to send data to healthcare providers, patients, and each other. So the one thing I think that is going to be a fundamental shift in the way health systems begin to prepare themselves for AI is to address this question of data privacy. And I think Angela mentioned a very interesting point where she said that a lot of this really depends on what kind of data is available, and she herself had to purchase data. So all of you all have innovations and disruptions that are dealing with swaths of data. Now you're collecting it across into, you are generating data in the work that you're doing. You're also using reams of data in the analysis that you go through to actually produce, certain decision-making tools. So what are your thoughts on data privacy? And where do you think the link between digital disruptors like yourselves and health systems that are going to embed you need to interface? What kind of checks and balances do you have in place with the kind of work that you're doing that can offer some kind of consolation to the government, to the system where you might be embedded in, to offer some kind of consumer trust? So let's start again at the top of the line. Let's start with Lillian. You deal with, literally across social media platforms. So where do you see the kind of work that you're doing, and how does it relate to issues around data privacy?
Thanks, Priya. And it is a tough question. We've actually been wondering how to deal with that. As I was answering the earlier question on women and girls accessing phones and smartphones, one of the key challenges is even privacy. They don't have their own phone, so if they have to access messages, they have to use somebody else's phone, and that has been a big risk. And you have to program with them to think through, how can I get this message to you confidentially without putting you at risk? But we know that's a big risk that comes to them. But at the same time, by not giving them information, you're also excluding them from being able to access essential services. So this has to be led by them from the community to guide that. Maybe you can send if it's a sensitive message, you send a coded message that it sends in advance. And if they respond either yes or no, then you know you're safe to go on. But also advising them to delete the data. But the truth is there are big risks in terms of data. We now have a Data Protection Act, but ensuring that that is implemented has also proved to be, I know it's challenging, and there's still systems being put in place to make sure there's a data commissioner and having all that. But it might be more expensive, but it is essential because we are putting a lot of people at risk, and there is that challenge of who owns data. We've also seen it with I mentioned we work with men who have sex with men, and they face the risk of, they refuse to have data collected on them because of fear that it will go to government. And we have to respect that right and not collect sensitive data about them or identifiers. Thanks.
Fascinating. Thanks for outlining some of these. Amalia, you're really dealing with medicine, and you also talked about the role of stakeholders and collaborating with stakeholders in order to be able to create the kind of information that your program actually sifts through. Where does this lead with privacy? I mean, medicines are a contentious issue, right? And every country has its own ways of protecting, information. How has your intervention dealt with this?
We aim to, this approach. For this approach, we aimed the main user of this approach would be the medicine regulator. And you are right, Priya, that medicine is a specific item, so it's highly regulated. We think that when the medicine regulator somehow eventually use this approach, they would also need to combine their regulatory data, which they routinely collected, with other data like procurement and pharmaceutical market data. So I guess the price, and we don't foresee for now that this approach will be a public facing tool, so it's not available or accessible widely to public, but only to selected user, which is the medicine regulator. So I guess the question about data privacy is somehow probably more related with data accessibility, because in order for the medicine regulator to make this tool works, it has to be combined with other data sources. And some of the data that we're using now is from private data provider, which also needs or requires additional costs or payment. And it's not, and for government standards, it might be quite expensive to purchase those data. So I think that's the main homework to think about in the future is first how the data could be made accessible for the medicine regulator to employ this approach.
Great, thanks. And we're almost out of time, so really very quickly, we'll have Angela, Jay, and Sailesh maybe touch upon this. Will regulation and management of health data change significantly, and will consumers be more willing to share their health data? So where's the element of trust? Maybe 2 minutes each of you, and then we will wrap out the session. So Angela. I think we may have lost Angela. So let's move on to Jay, and Sailesh, you can have the last word.
Thanks. Just to echo what Lillian said earlier, and that's to collect only what is absolutely necessary to do the work, and not just hoover up everything you can. And in compliance with the Data Protection Act that Lillian also mentioned, one key piece is to get consent from the users. Let them know how we're going to be using the data and for what reason, and just inform them about the mechanisms in place for security and privacy. Thanks.
Great. Sailesh.
I think a very important issue, data confidentiality and privacy in this current scenario when you read about data leaks every day in the newspaper or other media. So I think very important to follow all the ethical principles and ensure importantly that you collect what is needed, you store it well, and when you analyze or report, you use or you transfer among investigators or countries, you use only de-identified data with all personal identifiers removed so that people can't be identified in any case, even if the data is leaked or gets stolen in some form. But I think very important, and right now, apart from federal or central government regulations, states are also very concerned about this. And when we work with state health systems, one of the questions they have is, how are we going to secure the data? What data are you going to use? So I think people are also getting better informed, and the health system stakeholders are also getting more concerned about how people's data are going to be used.
Great, thank you. I think with that, we're out of time, but it's been a fantastic discussion. I've learned a lot, and all the best in the future initiative. Thank you for tuning in, and have a very good night. Thank you.
Thank you very much.